Hi, my name is Dr. Rotimi Johnson. I'm a board-certified vascular and interventional radiologist of RJ Medical Group Incorporated. Today, I will be speaking about uterine fibroid embolization. This procedure is also known as uterine artery embolization. At the end of this talk, you should be familiar with how a uterine fibroid embolization is performed and the pre-procedure requirements, the reason for doing the procedure, and you should be familiar with the follow-up and the expected outcome of this procedure. First, for you to be considered for uterine fibroid embolization, you should have a fibroid, and the fibroid should be causing symptoms. Okay? So what are fibroids? Fibroids are tumors, they are benign tumors of a woman's womb. They are made up of smooth muscles and they can present in different parts of the woman's womb. They can be in the inner lining, in the middle layer, and outer lining. They can be small, they can be big, they can be 1, they can be 30. They cause symptoms, and the symptoms that they cause range from prolonged, heavy menstrual bleeding. These women come in and they complain of pressure in the pelvis, pain in the back, pain in the abdomen. Sometimes, have women who wake up because they've wet their bed because they're not able to control their bladder. There's a lot of symptoms. When these fibroids cause a lot of bleeding, they can cause a life-threatening anemia, and these women have to get blood transfusion. They also cause fertility problems when they block the fallopian tube and prevent the sperm from traveling or the fertilized egg from traveling, or even when they cause a problem when the fertilized egg cannot even enter the uterus and implant and begin to grow. So now when a woman comes to see me in the clinic, the first thing I do is do a history. Find out about a medical history, the drugs she's taking, if she has any drug allergies, if she's had any previous surgeries. I do a physical exam on her and confirm the presence of the fibroid with a pelvic exam. Another thing I do is order imaging tests. And the two imaging tests I like to order are ultrasound and MRI, and that depends on the availability. When I'm in the US, I typically order MRI, but when I do this procedure in Nigeria, I can order an MRI or I order an ultrasound. They both work. When I review the imaging and I look for the location of the fibroid, the number of the fibroid, and the size of the fibroid, and I also look to see if there's another type of tumor that may coexist with the fibroid. One of the things I look out for is a tumor, another benign non-cancer tumor is called an adenomyosis. Adenomyosis. It's very important to identify this tumor because if a woman who has adenomyosis undergoes a myomectomy is the surgery where you cut the uterus and remove the fibroid. They can have a life-threatening bleeding. And sometimes the woman's uterus may have to be removed completely to save her life. And this will be devastating for a woman who is going in for fibroid treatment to get pregnant and then losing her womb. So the only surgical treatment, if you want to do surgery for this adenomyosis, is to do a hysterectomy and remove the entire womb. Okay, but that would be a problem if you still desire pregnancy. For these women, I still do uterine fibroid embolization, It's effective, 60 to 80% effective in these women. Okay. Beyond the imaging, I also do lab studies. I do a CBC to look at their blood count, see if they have anemia. Look at do the BMP to look at the kidney function, because I'm going to use dye for the procedure and make sure they can tolerate it. I also look in the pelvis to look at some other causes of pelvic pain that may not be related to fibroids. Okay? Once we've decided that the procedure will happen, my patients come in on the day of the procedure, and I have my nurses place an IV in their arm in the holding area, and they get IV fluids, and I see them on that day and do another brief physical exam and history, and discuss the risks and the benefits and the side effects of the procedure. After that, we transport the patient into the angio lab where we do the procedure. We place this patient on their back, and we put monitors to look to check their heart rate and their breathing during the procedure. We give them sedation through the IV. The sedation is morphine and Valium type medicine. It puts them in the twilight zone and helps them relax. Depending on the woman's preference, I can do this procedure through the wrist or through the groin. The preferred site is prepped and cleansed with antiseptic, and sterile drapes are placed on the body, on the wrist or the groin. I anesthetize with the skin. I anesthetize the skin with lidocaine, and I use ultrasound to gain entry into the artery with a very tiny needle. After that, I remove the needle over wire, and through a series of exchanges, I place a tiny catheter into the artery. I then guide the catheter to the woman's pelvis and into the artery of the uterus under live X-ray guidance. This X-ray is very low dose, and it's not a problem. Once in the uterine artery, I inject some dye and take an X-ray to see the fibroids. The next step of the procedure is the embolization. Embolization means to block off the blood flow to an organ. And for the embolization, I use microspheres, different vendors, or PVA particles, and I mix these particles with IV dye and inject it into the artery of the uterus. And when I do that, it turns out that the fibroid takes up almost all the particles because it has abnormal blood vessels inside, but the uterus doesn't take up a majority of the particles. I do that for the artery on the left side and the right side, and essentially start off blood supply to all the fibroids in the uterus. Whether it's one fibroid or whether it's 30 fibroids, I cut off the blood supply to all the fibroids in one session. Once this is completed, I remove the catheter from the uterus artery and then close the artery in the hand or the groin with a closure device or a pressure compression device. The woman is then taken to the post-procedure area where she's monitored by my nurse for about 2 hours, and after which she's able to walk. Typically after 6 hours, I send these women home, or some women I keep overnight till the next day to control their pain. During and after the procedure, there's severe pain that these women experience, and this severe pain typically lasts 24 hours. I manage this pain with morphine type medicine and with non-steroidal medications, and this typically helps the women deal with the pain, but I assure the women that the pain is because the fibroids are dying off. They're being stopped with blood supply. Typically, 24 hours after the procedure, there's return of blood to the uterus. And by the time I see these women in clinic for follow-up a month after the procedure, the every bleeding, every prolonged bleeding during menses is corrected and stopped, and they have normal menses. At the same time, those fibroids, when they're large and hard, they've softened up. And these women tell me, okay, yeah, before I wasn't able to bend without pain, and now I can bend. Then I know that the pressure symptoms has been resolved. Okay, I then bring the women back in about 6 months, and I do another imaging, either with ultrasound or MRI. And when I do this, I'm looking at the size of the fibroids to make sure that they are getting smaller in size over time. I typically expect a 50% decrease in size of these fibroids. So for women that are followed out for 4 years, these fibroids continue to get smaller in size and doesn't come back. A question that I get frequently about fibroid embolization is the effect of this procedure on fertility. And I tell these women that many studies have shown a lot of these women who've had fibroid embolizations have gone on to have successful pregnancies. However, I would recommend that when a woman has had fibroid embolization and is pregnant, she should have a scheduled cesarean section. Now, additionally, some investigators have done studies measuring the FSH in a woman before and after the fibroid embolization, and they did not find any changes in the levels of FSH in women between 35 and 45. And FSH is the hormone that is responsible for preserving fertility. That's how we measure if a woman can still be fertile. One other thing I would like to say is that this procedure has been practiced all over the world by interventional radiologists, and hundreds of thousands of these procedures have been performed. The first doctor to write about it was Dr. Rotimi, who was a French doctor, and he found out about the procedure when he and his colleagues were looking for a way in which to reduce the blood flow during myomectomy surgery, and they did an embolization in these women with fibroids. And what they found out that most of the women never did come back for the myomectomy surgery because their symptoms went away. And that was the birth of the uterine fibroid or uterine artery embolization procedure. Very, very rarely, a woman who may be waiting to have a fibroid embolization procedure or a myomectomy procedure, or who has had a uterine fibroid embolization procedure, may have a very fast growing uterus. This is abnormal. Okay. When this happens, there's a very rare tumor that doctors and patients need to be aware of, and that's called a leiomyosarcoma. It's extremely rare, but it's a very fast growing tumor, and it's very frequently fatal. I just need to mention that. Uterine fibroid embolization is a very safe procedure. It's same-day procedure. There's no cutting involved. There is no bleeding, to my knowledge. There are no reported cases of anyone dying due to a uterine fibroid embolization. It's a procedure in the right candidate can be very effective, and it's as effective as myomectomy and hysterectomy. So this option needs to be given to women who are being considered for fibroid surgery. Thank you for watching. This is Dr. Rotimi Johnson. Please subscribe to this channel for more educational videos and check out our website, rjmedicalgroup.com, and check out our blog. Feel free to email if you have any questions. Thank you.